welcome everybody. It's 8 o'clock, and today's program we have called it as vaccine vacillation. So the COVID vaccine update is that India is ranked third after US and UK after having administered almost 90 lakh doses. 14 states and union territories have vaccinated more than 70% of their registered healthcare workers, including so-called backward states like Uttar Pradesh, Bihar, and Jharkhand. However, the sad thing is that 5 states and union territories have reported less than 40% coverage of their registered healthcare workers, and leading among them, unfortunately, is Tamil Nadu. Punjab, Chandigarh, Nagaland, and Puducherry are also on the list. If you look at internationally, Israel has managed to administer 70 doses per 100 population, and UAE has managed to administer 50 doses per 100 population, whereas Tamil Nadu has administered only 0.3 doses per 100 population. So what is the problem? Normally, we used to blame lack of education and lack of access to healthcare for poor vaccine penetration. But here it seems like better education and better access to healthcare has actually been counterproductive in the vaccination drive against COVID. So to take my own example, I was extremely hesitant to take the vaccine. Questions about efficacy and safety were dogging my mind. Should I take it? If yes, when should I take it? Which one should I take? I was lucky to attend one of the SIDS webinars which addressed all my questions and fears. And when my hospital made it available, I took my vaccine, first dose of my vaccine on 26th January. So I felt that maybe members of learning general surgery and others may also have similar doubts. And so Patta and I decided that we will have a session on this topic to help people make an informed decision. So we have a leading light, Dr.Ravi, who is currently the nodal officer for genomic confirmation of SARS-CoV-2 government of Karnataka. He is also the co-chair of DBT Scientific Advisory Group on COVID-19 vaccine. He is a visiting professor of microbiology and immunology at the University of Liverpool. Dr. Ravi did his MBBS from Madras Medical College and his MD microbiology from JIPMA, where his interest in virology started. He founded the Department of Neurovirology at NIMHANS, Bangalore in 1985 and recently retired as the senior professor and head of the Department of Neurovirology. And he was also the registrar and dean of basic sciences in NIMHANS, Bangalore. His areas of interest include public health virology, including outbreak investigation, development of indigenous diagnostics. He led Karnataka's response against COVID by setting up testing centers across the state. He has special interest in pathogenesis and immune response to viral infections. And if you just Google virus Ravi, you will find all his public statements on everything from chikungunya to Japanese encephalitis to COVID to the vaccine, the works. He's on the advisory board for Sputnik 5, the world's first registered vaccine against COVID-19. He's also very media savvy and a very powerful orator. I am sure you will enjoy listening to him. Along with him is Vidyalakshmi Devarajan, my close friend, and we call her ID Vidya because there are too many Vidyas around. She's a consultant ID physician in Dr. Rela Institute and Medical Center, Chennai. She did her MBBS from Rajiv Gandhi University, Karnataka, and her DND and FNB in infectious disease while training in Apollo Hospitals, Chennai. She has over 30 publications and she has co-authored 5 chapters. She's also a peer reviewer of journals including PLOS Medicine. Her special area of interest is infectious disease in transplant setting. I had the opportunity to work with her for a few years when she was with me at Fortis Mallar, and she was the backbone of the antimicrobial stewardship program, and we managed to make our protocols for surgical prophylaxis and usage of restricted antibiotics rationally. Because of her, she contributed in a big way. I tend to go at everything with hammer and tongs, but despite being younger, Vidya is much more politically correct, and so she gets the same job done by being nice as against aggressive like me. And to get the best out of these two people is Dr. Bishwarup Pal. He's senior consultant anesthesiologist at Kamineni Hospital, Hyderabad. He's currently in charge of both the transplant anesthesia and the surgical intensive care. He did his MBBS from Calcutta University and his MD anesthesia from Bombay University. After that, he did his postgraduate training in cardiac anesthesia from Madras Medical College, Chennai. Having come to Chennai, I think he fell in love with the South, and since the 90s, he has been mostly in Chennai and the southern part of the country. He's also done his FRCA from London. He's a regular contributor to Learning General Surgery and is not afraid to speak his mind or ask tough questions. He has been on both sides of the corporate management, both as a consultant as well as a administrator. So I am sure he will bring out the best out of and get us the maximum information out of these two speakers. Uh, so without delaying any further, over to you, Dr. Ravi.
Thank you, Vidya. And uh, let me acknowledge that this is a wonderful forum I came to know through Vidya, and I am very pleased and privileged to talk in this forum. I think what Vidya, ID, and I decided was that we'll have two short presentations. Dr. Bisharup, I hope this is okay.
Yes, yes,
And
I think fine.
then we open it for questions.
Mhm.
The idea of these presentations is not to insult you, but just for our own understanding that we don't miss some basic points before we open it for discussion. So if you find it too basic, don't get offended. It's only that I want to organize my thoughts in a particular way. So I'll share the screen. While I'm sharing the screen, I must tell you that the batch of Vidya, which we call as the big batch of Jipmer, because it was a double batch, is very, very dear to me because I had just joined Jipmer a year when they came and joined. And to be honest, I practiced all my teaching skills and honed them on this batch. They were very tolerant. Thank you, Vidya, and convey it to all your batchmates.
Sure.
Okay, what I'm going to do is uh, quickly run through some slides. Usually, in the last month and a half that I've been doing these programs, almost one a day, people ask me many questions. I'm not going to answer all these questions. I just put it up for you to read. We have divided between ID Vidya and myself who will do what. What I will do is to give you basic information on the vaccines available for use in humans across the globe and India, tell you how they work and what they promise. Most people do not have an idea, including, unfortunately, of healthcare professionals, more so doctors, do not have an idea what the vaccines promise. The vaccines do not promise the end of COVID, but they give you a certain assurance against, and we'll discuss those. Okay, what are the vaccines currently authorized for human use? Now, like HIV in the 90s, I think this is one of the most popular cartoons. If you Google, I think you will see millions of views on the structure of SARS-CoV-2 virus. As you all know, just to remind you, it's a spherical virus. It's an RNA virus. It has an envelope, and started in the envelope is a most important protein of the virus. In this case here, in this figure, it is yellow in color. It has a head and it has a stem. This is the spike protein. All properties of the virus, important properties of the virus, are vested in this protein. What are they? Attachment to cells, immunogenicity, antibodies to this virus also protect. COVID has brought out some new technologies or platforms for vaccine development. So I've tried to kind of group them here. Generally, viral vaccines, if you look at the history, they have been classified as whole viral vaccines. That means the entire virus is used in the vaccine, either as a killed form or as a um, inactivated form. Now, one of the vaccines that India has made completely indigenously is the Covaxin, and this is an inactivated vaccine, meaning they isolated the virus at NIV Pune, they grew it to large volumes, purified it, killed it using beta propiolactone, and this is used as a vaccine. This is the oldest vaccine technology available. The other kinds of vaccines are called subunit vaccines. They can be classified either as viral vectored vaccines, meaning you can carry a protein of SARS-CoV-2, piggyback it on another virus. And which is this other virus? The most popular other virus that is available today is adenovirus. And these are adenovirus from chimpanzee, or they are adenoviruses that are attenuated. There are two examples of licensed vaccines. One is the Oxford AstraZeneca vaccine made in India by Serum Institute, and this is called Co- Covishield, whereas the killed one, which I showed you earlier, is the one manufactured by Bharat Biotech. These are the only two vaccines currently authorized for emergency use in India. The third kind of vaccines that people are using, and this for the first time in human history, is to use virus genetic material. Now, one is virus genetic material as RNA, and the other DNA. Now, this is an RNA virus. This RNA vaccines are synthesized in the laboratory. So it's a synthetic vaccine. It's nothing to do with the infectious virus. They know the code of the RNA code of the vaccine. They attach the nucleotides and make a strand of RNA. And in this case, it is to the spike protein. And this is put into a liposome so that it can be delivered into the cell. If you give naked RNA, it will be destroyed by RNases in human body. So you have to protect it. It's encapsulated in liposomes. Now, COVID is the first time that after the advent of COVID that we perfected the technology of delivering this RNA into a cell and with 100% efficiency. Now, this is, in my opinion, a game changer. After COVID, this technology is going to be widely used for a number of infectious and non-communicable diseases. So, in my guess, mark my words, it is Nobel Prize winning technology. Now, there are two vaccines that are released. One is made by Pfizer and the other is made by Moderna. Both these are not available in India. They're used extensively in US and the rest of the world. Now, you should probably be aware as a group what are the advantages and disadvantages of the various forms of these vaccines. Now, if you take the nucleic acid vaccines like Moderna or Pfizer, the advantage is they're very quick to make. Today, if a virus variant emerges and you know the sequences in the virus variant in the spike protein, you can synthesize the new strand of RNA or DNA in the laboratory in a matter of weeks, do a quick bridging trial, and then release it for human use probably in a couple of months. So there is very fast track technology. Disadvantages are that first time in human beings we're using nucleic acid vaccines. What is the long-term effect? At this point of time, the honest answer is I do not know. But because it's only a gene coding, an RNA for coding a gene that is going to express spike protein, I expect that it will not integrate into host genome and produce any long-term effects. But that is an expectation, but the fact is we do not know. Live attenuated vaccines have not been released for human use. They are in the process. They are undergoing trials. We'll get them only probably in another 4 to 6 months. Traditionally, live attenuated vaccines are vaccines where the disease producing capacity has been eliminated or altered in these viruses. A classical example is the polio oral vaccine, which we've been using for years, which is very stable. And the advantage is they multiply. Because they multiply, they stimulate the immune system for a longer time. Inactivated vaccines, the oldest technology, time tested, extremely safe because you have killed the virus. And the other advantage is that they are displaying all the viral proteins, not only the spike protein. I say it is like a buffet where the immune system can choose and respond to various antigens, unlike subunit vaccines, which is a la carte type of approach. Same thing with subunit vaccines. The subunit vaccines today being considered for emergency authorization use is Novavax, which is awaiting clearance anytime. The examples of inactivated vaccines that are approved for use are Bharat Biotech Covaxin and Sinovac in China, and the RNA vaccines are Moderna and Pfizer. The last group of vaccines that I want to give you some information on is viral vectored vaccines. Basically, SARS-CoV-2 proteins have been piggybacked on another foreign virus, which is being shown to be very safe. It does not produce any disease on its own. And in this case, the most popular vector has been adenovirus. The Oxford Zeneca, AstraZeneca vaccine made by Serum Institute called Covishield is an example. And there is also a Johnson Johnson vaccine which is awaiting very shortly the authorization, which is promising in the fact that why it's promising is all the vaccines that I mentioned so far are two-dose vaccines. Johnson Johnson has shown promise with a single dose, but we still have to wait for the final results. Moving on to the next slide. Now, this is the information. The slides will be available for you to use. I won't go into details. As far as India is concerned, we have only two that have been approved for emergency authorization use: Covaxin and Covishield. Sputnik, which is an adenovirus vectored vaccine, is now undergoing phase 3 trials in India. Results will be out in 4 weeks. And after that, it will be submitted to the drug controller and the expert committee will give its decision. Similarly, Zydus Cadila, our own company, has made a DNA vaccine, which is in phase 2 trials, and we'll get the results in 4 to 6 weeks. The goal of any vaccination is to create immunity. One point I want to make is SARS-CoV-2 is a new virus. Nobody in the world is immune to it unless they are either infected, exposed, or they are vaccinated. All the others will either have to choose vaccination or the virus will catch up with them, and they will get infected. And if they infected, depending on the age group, they may either be asymptomatic and they may land up with mild, moderate, or severe disease. How do vaccines work? Vaccines try to mimic natural infection. You know, when the virus enters through the respiratory tract, it multiplies in the upper pharynx and lower pharynx, goes down to the lung, attaches through ACE2 receptors, and while it's multiplying, displays its proteins on cell surface, which attracts the immune system. The macrophage lineage of cells, which chop the proteins and present peptides to the immune system, the T helper cells, which in turn activates either the humoral arm, resulting in antibody production, and these antibodies, the good ones are the neutralizing ones. They in future will be able to prevent virus attachment to cells. Another very important arm of the immune system is memory cells. And memory cells are very, very important because when you get an infection after vaccination, they are the ones that quickly come into action. One point I want to make very clear, which I told you is very important and misunderstood, is the end point for all vaccines currently authorized for emergency use is protection against disease. It does not guarantee protection against infection. Infection and disease are two different things. I'm sure all of you know about it. So even if I'm vaccinated and I've developed all the correct responses, both in terms of antibody, memory cells, cytotoxic T cells, the virus can still enter my system. It can multiply in the upper respiratory tract. I'll be able to shed the virus. Consequently, I can be a source of infection to others. Remember this point. It's very important because when we come to the last slide, I'll tell you why it's important. I have known examples personally in Bangalore where a couple who got the first dose got infected and managed, from them, their elderly person at home got infected. So people who get the vaccine can get infected and can transmit infection to others. It's a very important point I want you to remember. How do you know vaccines work? I'm not going to give you a lecture. I'm sure all of you know, being clinicians, that there are the preclinical phase in development of a vaccine, where initially all vaccines are tested in animals. And for SARS-CoV-2, there are two animal models that are recognized. One is hamsters and the other is non-human primates. They are given the vaccine in various doses, and after that challenge with live virus, and they estimate the protection as well as the immune response in the animals. Only after it shows promise is when it enters phase 1 trial. Phase 1 trial is primarily aimed at determining safety, whether the vaccine produces any damage or not, usually restricted to 100 volunteers. Phase 2, where the objective is to see whether the vaccine is producing the correct type of immune response, generally called as immunogenicity. In phase 3, where large scale, usually for SARS-CoV-2, it's 25,000 to 50,000 volunteers, and where you have at least a third of them not receiving the vaccine but a placebo, and two-thirds classically receiving the vaccine. And at the end of the number of doses and a requisite period of 14 days, you look at the people in the both groups and see how many of them developed COVID disease. That is the end point that is scored, and based on that you calculate the percentage protection. A quick summary of the performance of the various vaccines available now. Oxford Zeneca vaccine, all vaccines in this table are 2 doses. There is nothing authorized for a single dose, whether it's the RNA vaccines like Moderna and Pfizer, or whether it is the viral vector vaccines like the Serum Institute or Sputnik. The Oxford Zeneca Serum Institute vaccine protection ranges from 60 to 90%. And the package insert says that if you give the second dose at 12 weeks instead of 4 weeks, your percentage is likely to be closer to 90%. But in India, we are following 4 weeks. I can answer any questions why we are doing that. Whereas both the RNA vaccines are uh, showing a higher level of protection, above 90%. And the Sputnik vaccine, very recently, a week or 10 days back, the Lancet paper revealed the results that it is 92% protection. The vaccination process in India has been streamlined, and there are various phases. It is regulated in terms of registration for vaccination. A lot of verification takes place, and actually vaccination occurs in three separate rooms, where verification and waiting, and then second room is vaccination room, and then you're asked to wait for half an hour to observe for any immediate side effects, and there are medical officers involved at vaccination site. I will not go into side effects. I think ID Vidya will do that. Two questions I will answer before I close. Should all those already infected take the vaccine? Certainly yes, because we know, following people who are SARS-CoV-2 infected, that in 3 to 5 months time, their neutralizing antibodies wane, and so they are likely to get infected. If you ask me how common is reinfection, reinfection is uncommon with the original Wuhan virus, but reinfection can be more common with the recently emergent variants. Will vaccines again work against variant viruses? Honest answer is data is still emerging. And from whatever data we have, depending on the vaccine, we know that the Pfizer and the Moderna and the AstraZeneca, as well as uh, the Covishield, the Covaxin, the Indian Bharat Biotech vaccine, there are preliminary evidences using serum of vaccinated individuals and doing a neutralization in the lab that it does protect. albeit to a lesser extent than it would protect the wild types virus. As far as the South Africa variant and the Brazilian variant data is still emerging, South Africa itself has put a hold on AstraZeneca because the vaccine is sera, there is data showing that it is not as effective. So this is all dynamic. Data is evolving. The honest answer is I do not know how effective they are going to be against variants. Now, one point I wanted to make, I missed the slide, is that even after vaccination, everybody has a responsibility to continue all the precautions you're taking now, namely social distancing, masking, and maintaining hygiene, hand hygiene, because, as I said, the vaccine guarantees protection against disease, not against infection. So we have a moral responsibility to uh, see that we are not the source of infection for others. Thank you. Over.
Dr. Paul, please unmute yourself. Please unmute yourself.
So I'm thinking let Vidya complete her presentation, and then we go through the Q&A session. Otherwise, the flow gets interrupted. Vidya, will you come in, please?
Yes, sir. Sure, sir. Thank you, sir. Very tough, I think, to speak after Ravi, sir, but I'll just share my slides. Here I go. We'll have a bit of overlap, but I think it's good to reinforce. So I'll take this opportunity to reinforce a lot of things here too. So thank you, Vidya ma'am, Ravi sir, Patta sir, and Pal sir, and all of you. It's a very nice forum, and thank you for this opportunity. So I would start with this saying, don't hesitate and vaccinate. This is going to be my start slide, and it's supposed to be my last slide as well. This is post-COVID sequelae that we see. Somebody keeps talking into thin air or talking into air. People, that is where 100 people around are listening. We used to call it delusion, but now it's called webinar. But I'm still very glad that it's because of these during COVID times that we've actually learned quite a bit, and we are able to carry out these into our practices as well. So that's it's a very nice thing that such webinars and technology has helped us. This unprecedented global need to develop a vaccine for COVID, it's good that we've had a vaccine, and researchers are really racing, and they've created a safe and effective vaccine to immunize and protect the global community. I know it's been a warp speed, that's what they call it though, where you have clinical trials and manufacturing almost going on, almost side by side, because this is a pandemic. You can't really wait to go over the entire period of all the phases completely with that particular duration of time. And this has been done to reduce the burden and spread of this infectious diseases. But what has happened is there's been so much of research and publication. In fact, that itself was a publication, and that's caused a lot of confusion amongst the healthcare as well as the public in terms of management, in terms of vaccine hesitancy too, where it's become a big challenge. In fact, this is one saying Tamil Nadu hesitancy challenges Tamil Nadu 19 vaccination drive, although India has been doing so well in terms of COVID so far. This is the latest data where even 58% of citizens remain hesitant to take COVID-19 vaccine immediately. That's even in Feb. We have about 58% of people covering healthcare who are still actually hesitant. I think it's all about perspectives. Sometimes you just need a different perspective on things. And ultimately, I think it's perception that matters, and things may actually change. Because what we all thought about vaccine some time ago has changed over a period of time, and there is acceptance over a period of time. And we've all made, in fact, a New Year resolution, not only to chuck out COVID, but also to accept vaccination as well. So I'll just go over to the cases. So we have a 40-year-old healthcare worker, no comorbidities. The institution actually provides him Covishield. So he seeks advice, can I take them? That was the first common thing that we saw right in the beginning. Even now, I'm sure we all get called to find out if I can go ahead and get vaccinated. First of all, yes. Should he get vaccinated? Yes, he's a frontliner. Second calls we definitely get after first dose of Covishield. Can he get vaccinated with Covaxin later? So what are the doses and administration of COVID vaccines? Suppose if 28 days have elapsed, then what should he do with the next dose? So what do we have now? This is the interim guidance from the WHO regarding the COVID, regarding the Oxford vaccines. So the Oxford vaccine says 2 doses should be given 4 to 12 weeks apart, just in case they have missed, say, the 12 weeks. It should be given at the earliest. Okay, they have to just take it at the earliest possible opportunity. There is no need to repeat the entire series again. And then what about the booster doses? Booster doses, currently there is no evidence indicating a need of a further booster dose once an individual has received 2 doses of the vaccine. So what about interchangeability of vaccine? That's not recommended. The current recommendation is that the same product should be used for both the doses. So you have received Covishield first. The second dose should be followed by Covishield. Yes, there is data on the Oxford AstraZeneca vaccine, which backs 12-week dosing interval. But currently, the MOH still recommends 4-week dosing interval. So in case you miss a dose beyond 12 weeks, please take it as soon as possible. Each vaccine series should be completed with the same vaccine which is initially used. No data to support the efficacy and safety of using one of the vaccines for the first dose and another vaccine in the second dose. Then we have another case, a 66-year-old gentleman who's a diabetic. He seeks advice because he has to get his pneumococcal vaccine, influenza vaccine, and COVID vaccine. He has no past history of COVID-19, but definitely he has risk factors. So when and how should he get vaccinated? So it's going to be sequential. So other non-COVID-19 vaccines should not be administered within 14 days of COVID-19 vaccine administration. So no data regarding safety and efficacy, but at the same time, if you have an emergency, it can be given at a shorter interval. So this is from the CDC regarding the Moderna vaccine recommendation that we have, where it clearly says that you have to have a 14-day interval before or after administration with any other vaccine. And in case you have, but just in case you have to give some other post-vaccine, post-exposure prophylaxis, or if you have to give tetanus toxoid containing vaccine as a part of wound management, you can go ahead. So emergency vaccination is okay to go ahead, but otherwise you have to do it in a sequential manner. So we have the next patient or our next healthcare worker, rather, I would say, a neurologist who has sarcoid and is on prednisolone. So he has, again, no history of COVID, but he's scheduled to receive Covishield. And he seeks advice whether to get vaccinated. Yes, he's on prednisolone. He is definitely, he requires, and he's a healthcare worker. Yes, he needs the vaccine. But immunogenicity and efficacy of the vaccine, and since he has a potential for severe disease in this population, the benefits will outweigh the risk and he may require it. But the efficacy of the vaccine in this patient may really not, we may not really know the efficacy of the vaccine in this patient. Then we have another patient who is immunocompromised on DMARDS or HSCT pre-transplant. So is Covaxin contraindicated in this patient? Okay. So currently, what do we have? This is the fact sheet for vaccine recipients of Covaxin. Currently, the Covaxin was on a clinical trial mode. So they don't enroll people who are on immunosuppressive medications. So they do. So this patient would not go on Covaxin, but yes, subsequently it's an inactivated vaccine, so it'll get recommended. So this is the next patient who is a 56. I mean, this is another healthcare worker who's a 46-year-old urologist with COVID-19 in September. So should he get vaccinated? He also has a SARS-CoV IgG positive.
I think this was very well explained, but again, to reinforce, individuals with history of SARS-CoV-2 infection should receive one of these vaccines if indicated. So, according to the ACIP recommendations, a pre-vaccination serological testing is not recommended in them. If SARS-CoV-2 infection is diagnosed following the first vaccine dose, the second dose of vaccine should still be given as per the CDC and ACIP. Yes, they could have persistence of IgG response to SARS-CoV-2. There could be robust neutralizing antibody response to them, which persists for months, but they could wane off. So as per I don't think we should just get confused. The recommendation is anybody with prior history of SARS-CoV-2 still need to get the vaccine. So when do they get the vaccine? According to the MOH recommendation, they have to wait for about 4 to 6 weeks, or 4 to 8 weeks rather, prior to getting it, in case they have the history, past history of COVID. But we do have WHO recommendations saying they could wait for about 90 days to 6 months. So we have the next case here, who's a 56-year-old diabetic and hypertensive, receives COVID-19 vaccine as the first dose. So somebody receives COVID-19 vaccine as a first dose, 5 days later develops fever and myalgia. So what is the possibility? Usually vaccine-related fever will generally occur immediately post-vaccination. So this is somebody who has developed fever and cough 5 days post-vaccination with presence of risk factors like diabetes and hypertension. So common things are common. Yes, when you hear hoofbeats, first think of horses, but consider zebras too. So I think we should rule out, it's mandatory to rule out COVID in such a patient. So just because he's already received the vaccine, it's going to take time. He needs a second dose, and it's going to take some time for him to develop antibodies. So, so this is the next patient. Then we have a 50-year-old healthcare worker who has history of pulmonary embolism and is on rivaroxaban. So what about them? According to the Ministry of Health recommendations, yes, the ones on blood thinners or hemophilia, decompensated liver disease require special consideration because they can develop hematomas at the local site. Anyway, these patients can actually receive the vaccine with a 23-gauge needle, apply proper compression. It's not a contraindication as such for vaccines. Then subsequently, we have a 65-year-old healthcare worker. He had severe COVID. He also had convalescent plasma. So when can he? He's recovered now and completed 14 days of isolation. So when should he get vaccinated? As per the ACIP recommendation, he should delay vaccination for 90 days. As per the MOH, that is Ministry of Health recommendation, he can wait for about 4 to 8 weeks and subsequently receive vaccination. Then we have another patient, another healthcare worker who's a plastic surgeon. He asks us whether can I get asymptomatic infection after vaccination? Yes, I think Dr. Ravi has explained it very beautifully. And what about CAB? That is COVID appropriate behavior post-vaccination. And next thing is the vaccine safe. So these are the 3 things that he asks us. Can I get asymptomatic infection? I think from the first talk, it's very clear. Yes, he could get. How long to wear mask post-vaccination? I think that's until good number of population are vaccinated, you need to follow CAB, which is hand hygiene, which is physical distancing, and mask. Universal masking is very, very important for prevention of COVID. So, and we also have to remember that these vaccines were developed and tested for their ability to prevent severe illness and death from COVID-19. So one may still get mild infection and spread the disease. The next thing is about the safety of the vaccine. This was the Oxford's Astra safety and efficacy data. And this data looked at the number of severe adverse events. That they found was one of them developed a transverse myelitis, but then they looked at, what they found was this was unlikely to be because of, they had an independent neurological committee considering the most likely diagnosis to be idiopathic. Then there was a case of severe adverse event that was reported 2 days after vaccination in South Africa. But then again, the group that patient belonged to was actually masked. So one thing we need to know is what is a severe reaction, what is a serious reaction. Serious reaction is something that will result in death, something that will result in inpatient hospitalization, and something that results in persistent or significant disability, or is life-threatening. So that is a serious reaction. So they haven't found too many of these or a lot of these in either of the vaccines, be it Covishield or be it Covaxin. So most of the side effects of these vaccines have been local, say pain, fever, myalgias, arthralgias, or these were the side effects that they found. Then we have the next subsequent, healthcare worker who is actually, this is another case, who's actually pregnant. So should she be vaccinated? And what is the recommendation in pregnancy? What is the recommendation in somebody planning pregnancy? And what is the recommendation in lactation? So this is the interim guidance from WHO, which says in pregnant women, they should receive the vaccine if the benefit of vaccine outweighs the potential vaccine risk, such as if they are healthcare workers or at high risk of exposure or have comorbidities, because all of us very well know that pregnancy, they can have either premature, they can have either low birth weight, or they could have even severe disease. So definitely such healthcare workers are at risk of COVID. So that is with COVID, or they could also have severe disease. So that's a high risk group. And if possible, you'll have to counsel them about the lack of safety data for pregnant women, and then they should be administered the vaccine. But at the same time, WHO does not recommend pregnancy testing prior to vaccination, or it does not recommend delaying of pregnancy because of vaccination. Our MOH, however, says that it considers this as probably a contraindication to vaccine. That is, pregnancy and lactating women have not been actually a part of the vaccine clinical trial. So we do not have enough data on them. So considering this, they have excluded them from the, they have considered this as a contraindication. So this interim guidance says, that is the WHO interim guidance definitely says, if in pregnant women, benefit outweighs potential risk. So you can go ahead and vaccinate, and lactating mothers also, yes. And this is about the AstraZeneca vaccine recommendations. So anaphylaxis to the vaccine compound is the only contraindication. WHO recommends this vaccine above the age of 65 persons with comorbidities. Persons receive convalescent plasma after 90 days can receive the the Covishield. And HIV immunocompromised and persons with autoimmune disease, yes, you can go ahead and vaccinate. So if a patient who's diagnosed with COVID-19 after the first dose, immediately after the first dose, should he still receive the second scheduled dose of the vaccine? Yes, that will become only a temporary contraindication. If I have acute COVID, it's a temporary contraindication or a provisional contraindication. So because if I have a COVID, I may spread it across there, and any acute illness for that matter will not generate an adequate immune response. So that is definitely a no-no for some time. And the antibodies that I develop may interact with the vaccine-induced antibodies. So definitely that is a contraindication for the vaccine. However, routine PCR testing prior to vaccination or serological testing prior to vaccine is not recommended. So will the vaccine virus act against the COVID-19 mutants? I think Dr. Ravi has answered that. We have the South African variant, which actually poses a little bit of decreased vaccine effectiveness against mild and moderate disease because of the B1351 variant on a very small sample size and substantial loss of neutralizing antibody activity. So yes, that's about that. And what about this patient who's a physician on DMA-RDS? He takes the COVID-19 vaccine, but subsequently 3 months later develops fever, cough, diarrhea, and turns out to have COVID, PCR positive, CTSS 26 out of that, CT severity scoring of 26 out of 40. Yes, this could be vaccine failure. Generally, nothing is foolproof. So what is the common cause of vaccine failure? The DMA-RDS are considered to be one of the causes for vaccine failure in be it influenza vaccine or pneumococcal vaccines. I think they could have decreased vaccine immunogenicity. So this is one cost that you'll have to think of in such patients. So then you have a cardiologist who's actually waiting for an mRNA vaccine. So what do you think you should do? So vaccines, we all know that have completed phase 3, and Dr. Ravi gave us more insight about it. So these are the available vaccines as of now. And you know that you are at work this way, but you know how your patients are, of course, with the masks all around. And you know, I mean, our habits are very difficult to change sometimes, you know, irrespective of the number of times that we reinforce. So I think we should just go ahead and not miss the bus and go ahead and vaccinate. So that's the advice that we would give to our cardiology friend. Don't wait for the mRNA vaccines to come. So basically, that the vaccines that we have now are Covishield and Covaxin. Covishield is the Oxford vaccine, where it's almost like you've seen the data and are convinced it's right for you, and you go ahead. And Covaxin, yes, you haven't seen the data yet, but someone else says it's good for you. So, and it's safe enough. So these are the two that is available to us. That there ends my talk. I'm not an expert on COVID-19 or COVID-19 vaccine, but I don't call this cure, but then I think it's one way forward to end the pandemic. Thank you.
Hello. Yeah, thank you, Vidya, and thank you, Ravi. I think even in the present situation, I think I sent a message to Vidya before the program a couple of days ago that the only clarity that I have is that I don't have a clarity. And probably that's true for most people. So I have a very broad-ended question in the beginning. Either of you could take it up. That is, what do you think is the cause for vaccine hesitancy among healthcare workers? Because if HCWs are not convinced, then how on earth we are going to convince the common population? Could you address that? Because I'm not much concerned about the molecular technology of the vaccine. I'm only concerned, is it going to work? Is it safe? Or is everybody going to take it? Could you take it up?
I'll go first, Vidya.
So one definite thing is, I think the concerns on safety. That is one thing. So I'm sure a lot of them definitely question. And since it's developed in a very short period of time, you know, the phases, the period of time, it's not like how the routine vaccines trial go. So they think that it's not really safe. It's not being studied enough.
Right. Ravi, could you please?
I would like to place the following facts before Vishwaru.
Yeah.
This is, we are living in an era of information explosion. I think what, as doctors and as healthcare, at least doctors among healthcare workers, should definitely be very inquisitive and ask questions before they take a decision. This is the era of evidence-based medicine. Having said that, unfortunately, there are so many sources of information, 90% of which is absolute junk. We are dealing with an era where WhatsApp University overrules Lancet and NEJM publications. Non-peer reviewed opinions and data is shared extensively in various forms of media. And people get carried away, and healthcare workers are no exception. So I think one has to definitely rely on reliable sources of information. Having said that, what are reliable sources of information? Traditionally, reliable sources for information for infectious diseases are the World Health Organization, the Center for Disease Control, and the respective official mouthpieces of the ministries of health, and of course, publications. So I think if one learns to sieve the chaff from the grain, there is absolute clarity. And I again want to make a point that there are only two ways you can get immunity to this infection. A, you have to be infected, or B, you have to be vaccinated. If you choose neither, the virus will catch you. It's your choice. You decide whether you want to get vaccinated or not. Over.
Thank you, Ravi. Ravi, one of your slide, one sentence is still rankling my brain. That is, this vaccine is not going to prevent infection. It is going to prevent the disease. Now, I don't know whether this truth has settled down or sunk in on all the listeners, because at least I started thinking when I am taking hepatitis B vaccine, uh, it is preventing the disease and it is not able to prevent the infection from entering my body. But what is the difference here is, now that I have taken vaccine, I can still carry the organism from my hospital or anywhere and bring home and still be a potent source for my people around me. Do you think this very fact must be well publicized, that vaccination is not a route to drop the guard?
I entirely agree with you, Vishwaroop. In fact, I'm not talking through my hat. Uh, my son is an emergency physician. I won't name the hospital. He's a faculty in an emergency medicine department of a medical college. He and his colleague both received Covishield vaccine about 3 weeks back. A week back, my son's colleague found his father symptomatic, an elderly gentleman with cardiac comorbidities, got tested, and that gentleman has never gone out of the house. Okay, he's never gone out of the house, considering his comorbidity. My son's colleague and his wife both work in the emergency department, both received the vaccine. A day after the father was diagnosed positive, they also developed symptoms. All of them were COVID positive. Epidemiologically, this clearly tells you that the source of infection in the elderly gentleman was the two family members who are working.
Yes.
So,
who had this?
So this is very clear that you are not going to be guaranteed protection against infection. This is something that I've been repeating till I have a sore throat. Even among doctors, it does not sink. I'm glad you raised the example of hepatitis B. Hepatitis B is different from a respiratory virus like Sarsko.
I gave that example only
very glad you raised that example, and that's a very wonderful example. And here is an infection. As of now, none of the vaccines are going to provide sterilizing immunity. What is sterilizing immunity? That even if the virus attaches to human cells, it cannot multiply. That kind of vaccine, there is promise, but I don't know whether the promise will be fulfilled. That will come probably from effective nasal vaccines, because they will induce a local immune response, which will immediately neutralize the virus and prevent it from multiplying in the nasal mucosa. Till we get such vaccines, all vaccines currently authorized for use protect against, as Vidya also reiterated beautifully, ID Vidya, severe disease and moderate disease. Mild disease and asymptomatic infection, there is absolutely no guarantee. Over.
Thank you. I have
Vishwaroop, I request, your hand is blocking your view.
Oh, okay. Sorry.
With the mobile phone, can you keep your hand down?
Yeah. Is that okay now?
Yeah, fine.
Yeah. Ravi, I need to ask you some, Ravi and Vidya both. In fact, these questions can be, please give a combined answer. You see, Ravi, what in your prediction, presuming that 80% people become compliant in terms of accepting the vaccination. Now, also parallelly, we are also getting data from ICMR focal studies in heterogeneous manner about such and such city 40% seroprevalence and such city 30% seroprevalence. And this is never going to be homogeneous in this country. So what you see is the way forward that the places where seroprevalence is less, there should be more vaccination, and where more seroprevalence, there can be less vaccination? It is my very simplistic approach to the situation. Please.
Let me take that question. I think you asked a very important question because this has been plaguing the social media, and it's out. There's too much of information out there. Vaccination should be de-linked totally from seroprevalence.
Okay.
Let us be very, very clear. It's got nothing to do with seroprevalence, because seroprevalence tells you whether you're exposed or not. And irrespective of whether you're exposed or not, everybody requires the vaccine, because immunity following infection or exposure is short-lived. So we do not have enough data to say, okay, if you have been exposed 6 months back, then you can take the vaccine. But if you're exposed just 2 months back, you still have antibodies. I mean, all that is very messy. In public health, it is too complicated. Right now, we know vaccine does not harm an already infected individual who has antibodies, because the trials included people who already were exposed in antibodies, and there are no special adverse events in them or more toxicity in them. So the best approach available is every city, irrespective of seroprevalence, should aim for maximum vaccination of healthcare workers for two reasons. A, you provide confidence to a common man by taking the vaccine. B, you are at highest risk, and should there be a second wave, of which there are some indications, imminent, it's there at our doorstep, healthcare workers will fall prey to it first. So I think these are the considerations people should have in their mind. Of course, the choice is theirs. Over.
With your
Yes. So,
permission,
Vidya,
Dr.
please.
Kishore,
Please.
I would like to call Sanjay Arora, who's a pediatrician in US. He was a volunteer in the Moderna trial for the vaccine. So Sanjay, a bit about how the trial works and what your first-hand experience.
Hi there, guys. Sorry to be joining late. Can you hear me?
Yeah.
Yeah.
Awesome. Well, thank you so much for arranging this, Vidya, and thank you to the speakers. Sorry I missed most of it, but I'm looking forward to the video of it. So, me and my wife joined the Moderna trial last late summer, early fall in the U.S. And they were scrambling to get volunteers because of all the issues going on with the unknowns, and also at the same time there was this person in the UK who had been paralyzed when they had gotten the vaccine. It turned out to be unrelated, but they were looking for volunteers, so we had volunteered and we had 50-50 chance of getting it, and we didn't know what we received, but clearly we had symptoms, and we knew that we must have received the vaccine. And I spoke to Dr. Lindsay Baden, who's the author, who's also at the Brigham, where we received the vaccine in Boston. So, I think there was hesitancy then, and I'm also a vaccinator in the sense that I volunteer to give vaccines to people. And I was just there about 3-4 days ago. I gave about 75 shots to public in general. I was one of the 4 people. We had about 300 vaccine doses available to us of, I believe, yes, we had the Moderna one. And it was disappointing for me to see that almost all the people who came there were white people. Right? There was not a single brown person, not a single black person that came. And that was disappointing. So there's a lot of vaccine hesitancy here in the US, and there's a lot of distrust of the system. And I think our leadership in the previous, I don't know your political leanings, but our leadership, the previous, which was there, did not help. Every vaccine site you go to, there's a police guy out there, right? There's just making sure everybody's safe. But, I have to say that people of color don't like to see that. They want it to be open. They don't like to see, because of all the history of distrust with medical system, that Tuskegee was one of the things where they give syphilis to black people, right? That was a long time ago. But still, there's distrust of the medical field amongst the youngsters, the distrust of authority, and the political climate has not helped. Hopefully, that'll get better. But those are the two things we see. Also, there's this, these celebrities here are anti-vaccinators. So measles vaccine, for example, you know, there's all this stuff about MMR that had come out about autism and stuff, and autism is very prevalent in the US. And people are not inclined to get it, even though the study was debunked numerous times over in Lancet. There's hesitancy from that part, from all these hippie folks who are anti-vaccinators. They are against doing that, and they want to. They deny their kids, for example, they're crunching granola people. They don't want to give vitamin K when babies are born. So there's the hesitancy in the Black people. There's also hesitancy in some of the people who want to be earthy, clean, and all that stuff, who want to just go with the flow. So those are the two things that I'm seeing on the ground in people. So those are my comments, Vidya. Thank you.
We also have Pavitra, who has done a lot of original work on coronaviruses. Pavitra, would you like to say something? Unmute yourself, please.
Hi everyone, thank you for inviting me, Vidya. So I have a PhD on coronaviruses, which when I did the PhD, nobody thought was going to be of any importance, including myself. All of a sudden, I'm in the middle of this pandemic, and there's all this rubbish WhatsApp going on, which Dr. Ravi said so eloquently. A couple of things I do want to say is, one question about why there's hesitancy among healthcare workers that I see. I run a diagnostic lab. What they're saying is, well, we've seen family get it and most of them are okay, so we don't feel like we need to get it. So that's something that we face quite often in my diagnostic center in terms of the phlebotomists and the lab technicians. Regarding lactating mother, I am a lactating mother and I chose to take the vaccine when my son was 3 months old. I plan to take the next shot in this upcoming week. So far, all good. There's no issues, and I chose to take it because the current recommendation is that if you are COVID positive, a mother can breastfeed the baby. So why not, when you take a vaccine from which you're not bound to get any kind of infection? So that was my very straightforward logic behind taking this vaccine. And my husband was one volunteer for the Covishield vaccine, but I don't think he's finished with his final follow-up yet. So we don't know whether he had the vaccine or the placebo, but all well so far. We've still continued to isolate, mask, and distance, but that's my experience so far. If there's anything else other than this fantastic talks by Dr. Ravi and Dr. Vidya, I can maybe tell a point or two. That's about it. Thank you.
Over to you, Dr. Pal. Sorry for the interruption.
No, that's fine. That's fine. I'll quickly switch over to two clinical questions to Vidya. After that, I intend to come back to Ravi. Vidya, hi. Could you just tell us, should there be, if someone is planning a surgery, elective surgery, should that person undergo that elective surgery in the interval between first and second dose, or should he complete that and then go for the elective surgery?
Sir, if we really look at elective surgery, you're not talking about emergency surgery. If we look at elective surgery, I think it is better to complete the 2 scheduled doses, because just in case he gets COVID in between, then that was going to add to mortality. So I would suggest that he completes the 2 doses and then give a sufficient, at least a 2 weeks gap for him to build an immune response, and then goes ahead with the surgery. Everything depends upon the emergency or how elective the surgery will be.
I'm talking. So that is one. And second, in categories of elective surgery where post-surgery immunosuppression is planned, I'm sure you get what I am meaning.
Yes, sir. Yes, sir. Yes,
sir. So if someone is planning to undergo a life-related transplant 2 months from now, should that person complete mandatorily the vaccination before undergoing transplant? Or are you following any such protocol?
If it is 2 months prior, then I think, sir, as of now, because until some time ago, There was some hesitancy about, I mean, there was some literature about use of the non-replicating adenoviral vector vaccine. In fact, I have seen a statement about the concern about viral vector vaccine in some organ transplant societies as well. So I think if it is such a thing, then but then right from what I'm seeing now, I think it's okay to go ahead with the vaccine if the surgery is planned, say 2 months later. But if it's going to be anywhere sooner and immunosuppression is going to be on, then I would say finish off the surgery and then wait for the maintenance immune suppression to take place and then give the vaccine.
Yeah, so probably this gray area will not be clear. Correct me if I'm wrong, either you or Ravi. At the moment, none of us know exact gestation between the vaccine schedule completion and adequate immunity. And we possibly don't even know what is adequate immunity against whichever organism. Am I correct, Ravi and Vidya?
Let me come to that, Vishwaroop.
Yeah.
All trials have estimated efficacy 14 days after the second dose.
Right.
That means if the doses are 0 and 28, then day 42 is when they have the estimated antibodies in not every individual, but in a proportion of individuals, and found that is the time required for developing antibodies, as well as some small proportion of cellular immune response has been measured. So we know that protection kicks in 2 weeks after the completion of the required number of doses. How long will it last? God only knows.
Yeah.
Having said that, we learned from related coronaviruses like SARS-CoV-1 as well as MERS corona vaccines. They have lasted for at least a year because they have invoked memory cells, they've invoked T cell responses. So we presume this immunity will last at least a year. We know that from other respiratory viruses like flu and other viruses that it lasts for a year. In case of flu, of course, you keep changing because the virus mutates so rapidly. We don't know whether corona also it's going to happen like that. But as of now, for a year, immunity will last. I had just one point to add about what Vidya said. She said there's a lot of concern raised in organ donation, organ transplant societies about viral vectored vaccines. Let me make it very clear that all viral vectored vaccines are designed in a way that they will have only one cycle of replication in the host. After that, there's a suicidal gene which prevents it replicating further. It's not that the adenovirus is going to linger in my system for a long time. No, it's just one cycle of replication for it to express the spike protein, to sensitize the immune system, period. That's it. It's done. After that, the virus can no longer multiply. Over.
Right. Ravi, I have to ask you a delicate question. Delicate in the sense because I think you hinted, and I'm going to summarize that particular hint in a way that there has been claims, counter claims, creating more confusions and controversies. And now I'm restricting my concern about India alone. We have two types of vaccine available. I have seen you calling Covaxin as buffet, which is likely to meet the requirement of multiple attackers, multiple varieties of attackers. And Covishield is more goal-directed or a specific target-directed. And I think Vidya also hinted at in the same direction in her last slide in the form of love marriage and arranged marriage. Now, I know worldwide, COVIDology got hijacked by politics worldwide. It is not India. So in such a situation, I mean, my colleagues call me, in your hospital, you're getting Covaxin or COVID, you are in Hyderabad, are you getting more Covaxin? There's that. This kind of hesitancy, this kind of scattered opinions. You are a person from science and you went ahead and committed with that buffet and a la carte. Could you elaborate that too for us?
Thanks, Vishwaroop. I spoke mostly from a common sense perspective, and the experience of using killed vaccines for more than a century by mankind. The first large scale killed vaccine was the yellow fever vaccine, which received the Nobel Prize in 1903. Even today, it is valid. So is the Salk vaccine, which is the killed polio vaccine. They all induce good protective immune response.
Yes.
And in a killed vaccine, all the elements of the virus are exposed to the immune system. We still do not have sufficient data to say that what is the role, protective role of other proteins of SARS-CoV-2, which are also expressed on the surface. For example, the envelope and the matrix. So if the spike is mutating, which is what is happening with all the new variants, you can catch the mouse by the tail, not necessarily by the head. I'm giving you an analogy.
Yes.
That is in that perspective that I said that the co-vaccine or killed vaccines are a buffet. This is common sense. Having said that, is there evidence? There is a preprint released by National Institute of Virology, which has looked at serum samples from co-vaccine recipients and showed that it completely neutralizes UK variant to the same extent as it does the wild type virus. So that is the only proof. What about South Africa, Brazil? We don't have answers. But I personally would believe, from my experience and from my knowledge of immunology, that killed vaccines will be able to tackle variants much better than subunit vaccines, which are directed against a particular protein of the virus.
Thank you, Ravi. Vidya, I mean, anesthetist Vidya, not ID
Could we
Vidya.
take some of the questions in the chat?
Yes, that's what I wanted to.
Okay. So a very simple question somebody has: how do you find out whether vaccine has generated immune response after you take? Do you have a test or to check whether the vaccine actually did its job in you?
The answer is we do not have a commercially available test. The best test would be to measure neutralizing antibodies. The best way of measuring neutralizing antibodies is to do a virus neutralization with live virus, which is not practical. You need a BSL-3 facility. Very few labs do it. Having said that, surrogate neutralization tests are coming up, and some of them are coming up commercially available, which is where you measure the ability of the antibody to neutralize spike protein in vitro in the form of an ELISA. And that is just being approved. The tests are approved for measuring antibodies, but not in the context of measuring efficacy of a vaccine. This will take it's work in progress. In 3 to 6 months you will get that. There's a question by Dr. Ravi.
Someone said that I have no fever, I have no pain. Does it mean that vaccine is, not effective?
God forbid that it is the truth. I took the vaccine. I didn't have fever. I didn't have even anything. That is not true. Generally, what I must tell you is immune response is very brisk and aggressive in youngsters. That is physiology, right? Young adults always respond very briskly, and sometimes responding briskly can land you in problems as well. And that's how you get pain. Even now, the preliminary data that I have looked at and many people have looked at has found that those above 55 or 60 are having milder side reactions compared to the younger lot. And there are many reasons for it. One of them is the aggressiveness of the immune response. And second armchair theory of mine is for Covishield is that the elder population has seen various adenoviruses and they are not reacting to the adenovirus in the vaccine, whereas the youngsters have not seen so many adenoviruses and they're reacting to the adenovirus as much as they're reacting to the spike protein. That's speculation. There's a question by Dr. Reba, my dear friend and colleague and senior from JIPMER. Ravi, your opinion on second dose after 6 to 8 weeks versus 4 weeks as of now? Rebadi, we have no choice. Let me be very clear. I've taken it up at the highest level, repeated number of times, because the Covishield insert itself says protection is best at 12 weeks. I've raised this issue, and also WHO guidance as well as the Lancet publication. The government of India is very clear. It has to be 4 weeks for the following reasons. A, as it is, the dropout after one dose in India is very, very high. If you extend the duration, the dropout is going to be even more. That is the reason they are sticking. Having said that, few days back, Professor Vinod Paul, my dear friend, very close friend, came up on and said that maximum concession they can give is for 2 weeks. That means instead of 4 weeks, you can take at 6 weeks. And I'm told at the end of it, the portal will not allow you to take the second vaccine. So right now, maximum of 6 weeks that you can wait. Over. Any other questions?
The same similar question was asked by Dr. Kalpana as well. Should Covishield second dose be delayed to 6 to 8 weeks as there's some evidence of better immune response? And there's also a question from Dr. Ramesh. There's one study showed that lower dose as first and second dose as normal dose improves efficiency. What is your take on that?
Can you repeat that question? I can't see it.
There is one study that showed that that half dose study. There is lower dose as the first dose and the second dose as the full dose may increase efficacy. What is your take on that?
These are research studies. They're not being replicated in large human trials. So I would take it with a pinch of salt. I think it's better to go by available foolproof evidence, which would be the full dose 2 times, whether it's 4 weeks, 6 weeks, 8 weeks, 12 weeks. I think honestly, we do not have a choice in this country, as we do not have a choice of choosing Moderna or Pfizer or Sputnik or Sinovac or Covaxin. I know these are very important questions, but I would go back to what Vidya said. ID Vidya said, look, you're being given an opportunity to get vaccinated. As a great philosopher said, to live is to risk dying. So I don't prescribe anything. I'm not a prescriptive personality. I only put facts. Yes, the vaccine, anything above 50%, I would have taken. That's my personal choice. Because I am 65, I have a very severe comorbidity. If I catch the infection, I know I will be in ICU. My chances of being in ICU are much more. I'm very happy taking the vaccine. Of course, it's my personal choice. Use your wisdom. Weigh risks and benefits, as ID Vidya very correctly said. Do not get carried away by WhatsApp University or newspaper. If you want, go Google, choose a publication, read it carefully, and make your choice. Over.
Do you believe in herd immunity for COVID? That was the other question from Dr. Ramesh.
It's not a question of my believing or not. Herd immunity is truth for any infection, forget COVID. And what is herd immunity? When a substantial proportion of population gets infected or protected, the chances of transmission, the level of transmission will come down. But remember, again, misconception among our own fraternity I've seen is, oh, herd immunity is here, that means everything is fine. Herd immunity is what? 65%. 1/3 is still at risk. And if that 1/3, there's a huge surge, all ICUs will be filled and there won't be beds available for the needy. I want to warn everybody saying that herd immunity seems to be a utopian thing that we can shed everything and run back and be to pre-COVID times. I'm sorry, it is not. And it will take more than 3 to 4 years for the entire globe to be exposed or protected. By that time, there will be another a few million susceptible that would have been inducted into the society. So it's a long haul. It's a continuous story. We should learn to live with viruses and behave and treat them with respect. Over.
Vidya, I have a question. to Dr. Ravi. I've been given a little passport like booklet with saying I've been vaccinated. This book will have any significance when I travel abroad, or is it necessary to have one certificate of that nature?
I believe it is, Patta, because very soon you will start seeing that countries will start imposing restrictions on your entry. At that time, this piece of paper would be absolutely invaluable. Much like, I don't know if you have traveled to Brazil and South Africa, the yellow fever, yellow book that you carry, I keep it very carefully because I travel extensively. So I'm sure it will have a role and it will have its utility. So keep it carefully.
Thank
There's another question which says that one healthcare worker had 2 doses of Covishield, but after checking found there was no IgG. What could be the cause? And
Many of my friends have done these experiments themselves. You know, everybody. I'm so excited to see every doctor doing his own research and coming to conclusions. It's very exciting. Anyway, one of my very close friends got his sample tested 14 days after first dose and said, "I don't have antibodies." I said, "Don't worry, you will not have it even after the second dose. Relax, wait." Everybody does not react the same way. Their immune systems react differently. And this gentleman or lady whom you referred to, I don't know how many days after second dose. It could not be 14 days after second dose, because India, nobody has got a second dose after vaccination started. It's not 14 days. And even at 14 days, if it's not there, there's no need to panic and get concerned. People respond definitely. And also, antibody is not everything. There is also known as cell-mediated immune response. Over.
so what are the rules of quarantine for a physician who received 2 doses of Pfizer vaccine visiting India?
For all people, irrespective of receiving vaccines or not receiving vaccines, the quarantine is 14 days. And I fully am one of those people who have actually vociferously support that, because no vaccine is 100% proof. I may be Pfizer, I may be Moderna, but I can be in the 5%. Remember, there's nothing 100. There is no foolproof evidence. I mean, no vaccine gives 100% protection. You are a traveler, you have to be quarantined. Over. Period.
And there's also a difference being made about efficacy versus effectiveness, right? The two-wheeler giving 40 kilometers per liter under test conditions, and when you actually drive it on the road. So
Exactly. Exactly. There are many caveats to the efficacy that is claimed.
So, ID Vidya, this question: in case of COVID-infected patient who has received first dose of COVID vaccine, should he be given the second dose? You already mentioned that in your talk, but can you just repeat it? Somebody has received the first dose of vaccine.
Irrespective of their past history, yes, they have to receive their second dose, irrespective of the past history. I mean, if they have had COVID as well, they still have to, but they have to wait for their acute illness to come down. As per the WHO interim guidance, I think they can wait for at least 90 days to a little more than that, because you would have antibodies, but always remember, these antibodies can wane off, and these need not be neutralizing antibodies. That period of wait is for two reasons. One is that during acute illness, you would spread infections, even if it's mild, to the others in the vaccination site. Second, you may be producing antibodies on your own, which will interfere with the vaccine-induced antibodies. So for these reasons, and the third thing is, you give preference to somebody else for the vaccine while your body has already produced antibodies. So these are the three reasons where you can actually wait for your dose. But yes, you definitely need a dose of COVID vaccine.
There are a couple of questions with you from the Facebook group. One, Dr. Sagnik wants to know, is there any sexual importance chance with this vaccine?
None reported in the published literature. Let me tell you, most of the side effects, mild side effects people experience has got to do with the type of personality you are. If you're an anxious personality, you will definitely have pain at the site and you will feel fatigue. And so There are now people who are conducting extensive studies on looking at the kind of anxiety people are experiencing. Having said that, regarding this question, there's no evidence as of now. Whether it will be there, I have no idea.
Is there any relation between vaccine and developing encephalitis following
I think Vidya ID can take that question, but as far as I know, people have talked about neuroinflammatory syndromes following adenovirus vector vaccines as being reported in people who are being vaccinated by the AstraZeneca vaccine. That's the only paper I have seen. And encephalitis is not reported there. More often, it is acute poly-inflammatory demyelinating neuropathies that are. Vidya, you want to take that?
That's about it, sir. And even the 3 cases of, I think, transverse myelitis that was reported. In fact, one of them was said to be, by the expert group of neurologists, not unrelated to this vaccine. So,
there's another question. If I take a paracetamol after vaccination, will it reduce the efficacy of the vaccine?
Oh, that's
No,
questions.
it does not reduce the efficacy of the vaccine.
So I have a little different question. Right now, we don't have a choice. We get whatever vaccine we get, but let us assume down the line, maybe 5-6 months later, the vaccine is available in the public domain. In the sense, just like you go and buy your flu shot and take it, or go and buy your hepatitis and take it. So now I have taken my first dose of Covishield vaccine. You're saying that the government will allow me to postpone my second dose to 6 weeks, right? I need not take it at the 4th week. Is that what you're saying, Dr. Ravi?
That is what is not a written order. This is what Dr. Vinod Paul said in the interaction with the state experts. That the reason for that is that you might have had an acute illness at the time of second dose, or you might have taken a tetanus toxoid, or some emergency cropped up in your family. So up to 2 weeks, they are willing to
Grace period.
grace period. They're willing to give.
So suppose the Covaxin becomes available for want of a better word, I'm using over the counter kind of situation. So having taken 2 doses of Covishield, do you think it will be worth my while to take Covaxin maybe 6 months down the line if I'm planning to travel or something?
You want to shift between Covishield to Covaxin?
No, I will finish 2 doses of my vaccine as of now. At the end of 4 weeks, I take my second dose, and I'm kind of finished with this vaccination schedule. But since there is so much doubt about whether it works against the other variants and all, would I be justified if it were made, if it was possible for me to take Covaxin 6 months down the line because I want to travel, say, to Brazil or UK or whatever?
I really cannot answer the question because people are planning crossover trials now. Hopefully, you will have enough information on crossover trials where interchangeability studies are being planned.
I'm talking more about a supplementary thing rather than interchangeability. It's like every year take a flu shot. It's a different one.
Basically asking whether you should take boosters after another 6 months.
No,
I would say
Covaxin
that
because it's a full virus.
By 6 months, you will definitely have enough data on longevity of immune response following any of these vaccines. But remember, they all started their trials in October, November, December. So 6-month data will be out probably in another 2-3 months, and we will know if how long the antibodies or the T cell responses last.
Vidya, Dr. Virendra Nim has got a question. Actually, he says he had a classmate of ours who undergone liver transplantation for autoimmune induced cirrhosis. Then he also had transplant, is another immunosuppressant activity. Now, will the vaccine give rise to another third episode of suppressing my immunity?
I will answer it and hand it over to ID Vidya also. None of these vaccines are known to induce autoimmunity. There is no clear-cut evidence. So that if that is his concern, there is no evidence to say any of the vaccines induce autoimmunity. The second point I want to make to Virender is that because you are on immunosuppressants, the level of protection you can get out of vaccination may not be the same level that a healthy person will get. Having said that, you have to take a call on whether to get vaccinated. There is still protection afforded by vaccines. What is the protection in immunosuppressed people versus healthy people? The data is not very clear at this point of time. Over to IDVD.
Yeah, I think I'll just go with what Dr. Ravi said. Most of them with the transplant or transplant recipients have not been part of the vaccine trials. So we do not have data on these patients. So, so the efficacy of the vaccine on them is questionable. But the risk of COVID in these patients is definitely there. The severity of disease is also quite high in these patients. Not only because of transplant, but yes, also due to their other comorbid conditions. So I think, again, you will have to weigh your risk and benefit and go ahead and decide about the vaccine. Next thing is about the autoimmune part of it. As per the interim guidance by WHO, there is no data again on this, but if they are a part of the vaccination group, you should offer it to these patients as well.
So the other thing that was discussed in one of the other meetings I attended is that when you have a problem like a transplant patient, we have to make a cocoon around them, make sure everyone around them at least is vaccinated till such time as you make up your mind or reduce the immunosuppressant dose to acceptable level to be able to get an immune response from the vaccine.
Yeah, ring vaccination is definitely something that we actually advocate.
Right. Vidya Senior.
Yes.
Hi. Can I, Ravi and Vidya, I need to discuss a small math with both of you. Going back to this efficacy percentage, in India we have two names, Covishield, Covaxin. One has got a data of 62 to 90%. That's a big range. If I make an average of 62 and 90, it comes to 75. On Covaxin, I don't have a data. So if I presume both are having 75% efficacy, then I have to believe that universal immunization is the only option, because if I do a serial math, out of 100 people, if 50 are compliant, truly, out of this 50, 12 will be non-responder. So this 12 plus 50 who did not take vaccine makes it 60% people not vaccinated. So if I serially do this math, I come to a conclusion that unless we do universal immunization, we are not going to have 75% minimum protected. Am I correct in this line of thinking to both of you?
Yes, Bishwaru, you are correct.
Absolutely,
sir. So why I put this math to both of you is, at the moment it is like optional, personal preference, human right, all kinds of, like that Dr. Arora spoke from US. But can it not be a mandate? I know there will be, it is not pure science, there will be politics and all that. Like universal immunization for smallpox, polio, this, that. Can it be done that way, just as a public health policy wise?
Probably down the line it may happen. Right now, what is preventing it is the sheer logistics of availability of vaccines.
Yes.
Once that's why it is graded coverage that is taking place, at least protecting the most exposed and vulnerable first. Should there be a second wave, then these people will be there to take care of the sick. So that is the and reduce mortality. So you are right. If we had in the globe, we had, let us say, about 15 to 20 billion doses available, we can do universal immunization. But remember, because the process of vaccination will take 6 months to 1 year to reach all target groups. The entire activity itself, so it's time consuming. Over.
Yeah, I mean, I think once the vaccine volume is available, indirect mandate can be done, like you can't travel without this certificate. Automatically people, you can't do this without the certificate. So probably that's the way. Anyway, with the senior.
There is one sort of technical question from one of my colleagues. How will a phase 3 study for Covaxin be conducted since it's already being used under emergency use authorization?
Well, that is a very difficult question to answer. In considering the pandemic situation and the emergency, the government argues that they approved it for emergency authorization use. But what still perplexes me is, where is the data? Why is it not out yet? See, we started on January 16th. At that time, 22,000 people had already received Covaxin, and another 3,000 to 4,000 had to receive the vaccine. At least in the next couple of weeks, I hope I will see efficacy data of Covaxin out. But I think this whole thing was done only for as an emergency. It's an exceptional situation. The only other exceptional situation I know was in 2006 when Japanese encephalitis virus vaccine was introduced without any trial in the country, directly. And even globally, there was not very robust data available, but because of the huge outbreak that happened in Uttar Pradesh and thousands of kids died, straight away the vaccine was procured from China. It was not a WHO approved vaccine, but still it was introduced into the country. So there is one precedence that I know of. So far, no, thankfully, there is no concrete adverse event following Covaxin. But what is the level of protection? I think we will know only in a couple of weeks. ID Vidya, you want to answer?
Vidya Senior, I think from my side, I mean, I'm sure there will be endless questions, but from my side, I think I have tried to cover most of the non-technical questions that I had in my mind. Over to you, Vidya Senior.
So another question regarding, which is sort of part of our how to address vaccine hesitancy. How does one reassure patients regarding Covaxin since there's no efficacy safety data from a well-controlled placebo controlled phase 3 study?
I think by the time it goes to the third tier of the first phase, which is senior citizens, I'm sure the efficacy data will be out. It's only our group of healthcare workers we had to serve as within quotes guinea pigs. We will have the data, efficacy data out shortly.
So if anyone else has a question, we can give 1 or 2 minutes. Otherwise, we'll be winding up soon. I can't thank Dr. Ravi, Dr. Vidya, and Dr. Pal enough for because there have been countless meetings on COVID and probably enough on COVID vaccine as well. But despite that, you made it so informative and interesting that almost everyone who logged in stayed right up to the end. And I don't think we have ever had so many questions in. This is our 16th episode of Marvelous Medicine, and we have never had so many questions on the chat box or direct questions. So that shows that what we did was right. It was topical, and I'm sure it will help people make an informed decision and also to continue to be responsible even after being vaccinated. Anything you'd like to say to summarize, Dr. Ravi?
Nothing. It's been a great pleasure and a learning experience with every session that I do. As I said, use your wisdom. If you don't get vaccinated and if you're not infected, you're likely to get infected. So the choice is yours. Over.
Ravi, many thanks. Vidya, many thanks. It was a pleasure. Hope someday I'll meet both of you.
Good night, everybody, and we'll meet again next week. And next week's topic is intensive care for surgeons. So do log in next Thursday at 8 p.m. Thank you.
Thank you and good night.
Bye. Thank you, Patta. Thank you, Vidya. Bye.
Thanks. The wonderful session.
Thank you,
indeed.
sir.
Thank you.